All right, thank you very much, Dr. Felicia. I think now is my time, correct, to introduce my colleague. So, Dr. Afiqah, are you there?
Yes, I'm here.
Can you turn on your camera so we can have a look at your face? Okay, good morning, everybody. So, Dr. Afiqah is a senior lecturer at the Department of Social Preventive Medicine, Faculty of Medicine, Malaysia. She joined the department after completing her PhD at the University of British Columbia, Vancouver, Canada, in interdisciplinary science and combination of sociology and medicine. She was trained in public health for her master's program at the London School of Hygiene and Tropical Medicine in UK. Her research focuses on engagement in HIV care and harm reduction services among people who use illicit drugs. The epidemiological work that she's engaged in is informed by sociological perspective, which frame the research question within the wider social, economic, and policy environment. She also promotes the use of evidence-based practice in real-life settings from implementation science research and knowledge transfer with at-risk communities. More recently, Dr. Afiqah attended an implementation science training at Yale University, Connecticut in USA. Today, she will be talking about fundamentals of implementation science, drawing upon her experience through the Malaysia Implementation Science and Training, or MIS, program, which is collaborative between University of Malaysia and Yale University. So without further ado, can I invite Dr. Afiqah to start her lecture? Thank you very much.
Assalamualaikum. Good morning. Thank you for Victor for the introductions, and thank you to the Represent Health organizers for providing this platform, and also special thanks to everyone who was tuning in so early in the morning to join us as we talk about the journey from evidence to implementation, specifically how we want to put science into practice. So just a quick overview on today's talk. I will start by providing the fundamentals of implementation science, followed by how implementation science is being applied in HIV research, drawing upon a current study that my teams and I are conducting. And finally, to showcase the Malaysian Implementation Science Training Program, or what we call the MIS program, a collaboration between UST Malaya and Yale University. Although this talk is focused more on HIV research, the application of implementation science is broad. So I would like to encourage everyone to think about how implementation science can be applied in their own line of work. So the fundamentals of implementation science, some of the questions that you may ask yourself as researchers in your own respective fields are thinking how your own discovery can be put into use, thinking about the success of your clinical trials, the positive results that you're seeing from your own research. The new drug is safe and effective, but how am I going to get this into clinical practice? And even it's being incorporated in guidelines, how do I expand this? How do I scale this up? And this is what we say over and over, including myself, that we should all do something with all this research, quite forgetting that discovery on its own does not lead to actual implementation. Demonstrating impact does not lead to uptake by not just practitioners, but also uptake by patients. Organizations often do not foster a culture of change based on evidence-based practice, and once achieved, the maintenance of change is often overlooked, leading to going back to the prior state. And if we were to reflect the gap between science and practice, the leakage in the pipeline, as you're seeing here on the slide, depicts the journey right from the point where we begin to set priorities for research, research funding, to the generation of evidence through research, until the point where evidence are being incorporated as part of practice. It takes an average of 17 years for research evidence to reach clinical practice, for the benefits of a proven intervention to actually reach our patients. Fewer than 50% of clinical innovations ever make it into general usage, and it is estimated that 80% of medical research dollars do not make public health impact. for various reasons. And an example of the gap between evidence and actual use of the evidence is clear in the context of HIV research. So the first drug was described in 1987. It was described in 1964 before it was approved in the United States in 1987. So that's 6 years after the first reported HIV case. And this became the first HIV treatment. So a milestone in the HIV history has been discovery of triple combination antiretroviral therapy as a highly effective treatment for HIV in 1996, also known as HART or ART. And it was at this 11th International Conference on AIDS in Vancouver, British Columbia, Canada, in the year 1996 that researchers began to showcase the importance of HART, including data presented by Dr. David Ho, who was even featured on the front page of the Time magazine, and Dr. George Shaw on the billion copies produced by HIV each day, indicating that this was a viral infection that requires antiviral treatment, which is obvious now, but it was not at that time. And to name a few other researchers, such as Dr. Malas, who demonstrated that plasma viral load was a better predictor of progression to AIDS and death rather than the number of CD4 cells. And Dr. Julio Montana from British Columbia presented on the effectiveness of the triple drug therapy. And the science is clear, as demonstrated by Dr. Montana in a viewpoint published in Lancet in 2006. So this paper began by looking at the rise and impact of HART since its first use in 1996. And Montana and his team built the case for expanding access to HART based on the hypothesis that a prevention-centered approach would argue that treating 100% of HIV-infected individuals at once could greatly reduce HIV transmission. And the idea of treatment as prevention was born, which is the basis of the U equals U, undetectable, untransmittable campaign that we see today, meaning that if you're on treatment and you're adhering well, you'll suppress your viral load to undetectable levels, at which point you are unable to transmit the virus to others. And the concept was proven in 2011 with the publication of the HPTN 052 trial, in which immediate treatment with ART would reduce HIV transmission events by 96%. And this study was first funded in 2003. It's a 9-country trial of more than 1,000 couples, in which one partner was HIV positive and the other was negative. Participants were randomly assigned to receive ART either immediately or what we call early therapy, or after a decline in the CD4 count, which is delayed therapy. And the primary prevention endpoint was the proportion with linked HIV transmission in HIV-negative partners, shown on the y-axis with time on the x-axis. And you can see that not only early treatment was better than delayed, but the therapy was almost perfectly effective. And the result was published 8 years after the trial was first funded. And 11 years after the RCT started, UNAIDS announced the ambitious 1990 policy based on the treatment as prevention concept. So it stated that 90% of those living with HIV should be aware of their status, 90% of those who knew their status should be on HIV treatment, and 90% of those on treatment should achieve a viral suppression. And we know clearly that what we're supposed to do, we should be getting more people tested, and we should be getting people started on treatment as soon as possible, but not really how to do it. Based on current estimates, it seems like we still do not fully know how to do it despite knowing what works. So 23 years since HART was first introduced, 16 years after the treatment as a prevention strategy has been introduced, only 67% of people living with HIV are receiving ART, and only 59% achieved viral suppression, far below our intended goals. And this is partly because much of the evidence that is being generated answers the question what to do and not how to do it. So the field of implementation science, this is what it aims to do. It seeks to systematically close the gap between what we know and what we do, which is often referred as the know-do gap, by identifying and addressing the barriers that slow down or even stop the uptake of proven health intervention and evidence-based practices. And there are many implementation science definitions, as you can see here. And with these many definitions, there are also many different terms used in different countries. For example, in the US, it is known as dissemination and implementation science. In Canada, the term knowledge translation is used, but they all have the same purpose to help with the implementation of an intervention or program. And some of the core implementation science research questions are: what are the most effective techniques to improve the distribution and receipt of evidence? What are the most effective techniques to incorporate new discoveries and evidence-based practices into care delivery? How do contextual factors influence implementation success or failure? And how can these factors be modified to increase chances of success? And what are most effective techniques to de-implement practices that are no longer effective and replacing them with better strategies? So to successfully plan and execute implementation, we need to ask and answer a few questions which require us to look inside the box of implementation science. First, what are the evidence-based interventions? Next, what is the implementation strategy? How will you improve the uptake? Or how will you expand your evidence-based intervention? And to identify how well the implementation strategies are being delivered, you can measure the implementation outcomes. How well would the implementation strategy delivered? And then you can measure the service outcome to identify how well the evidence-based interventions delivered. And finally, you can look at the health outcomes to see what were the health impacts, just to see the overall impact of the program. And I will take some time to highlight 5 main reasons why implementation fails despite evidence that have shown that the intervention works. First would be the lack of clarity in the aim of the innovation or the intervention. We need to be clear on what exactly is the evidence-based innovation or intervention or practice that has been proven in clinical trials, and how do we want to go about it? What changes do we want to make that will result in improvement, especially in the uptake of these innovation or interventions? And what are the implementation outcomes? And next is the lack of understanding of the context, because the interaction of factors at multiple levels influences success or even the failure of interventions. An understanding of these factors would be really important to an effective intervention. The next point would be is not including people in the planning or the planning phase. So stakeholders are important to look at. They are anyone with an interest in the outcomes of the project. It can be the director of the organization, your HOD, a representative on staff, those who are going to implement the program, people working on the ground. And it's very important to get input and opinions from the stakeholders, who can also be our own patients whose lives are at stake. They can help with identifying potential barriers and facilitators to implement the program. And they can also provide support to overcome these barriers. And number 4 would be bad planning. Implementation plans should be well designed, well prepared, and guided, and most importantly, guided by a set of theories, models, and frameworks. So this is a schematic diagram that would enhance our understanding on the theoretical approaches in implementation science based on what we aim to do. So if we were to describe or guide the process of translating research into practice using process models such as the APIS model, the exploration and preparation implementation sustainment framework to frame my own IS research. This is my personal favorite, but there are also approaches, other approaches, depending on what you plan to do. If you're planning to understand or explain what influences implementation outcomes, you can look at using determinant frameworks or classic theories such as the health belief model, and also implementation theories. And if your target is to evaluate the implementation, there are several evaluation frameworks out there that you can use. And the other planning that is really important is to identify which methods you would like to use. And it's very common in implementation science to use a mixed methods approach, combining quantitative studies, like looking at implementing a strategy, using interrupted time series, crossover cluster randomized trial design, step wedge cluster randomized design trial, and even accompanied by qualitative components. And finally is the failure to build support for sustainability and scale up, especially in evaluating the fidelity of the implementation, which is the extent to which delivery of an intervention adheres to the protocol and program model which was originally developed. I'll take a moment to talk about an ongoing work in implementation science in the context of HIV research. So what we know in the current context of Malaysia is that harm reduction works in reducing the number of HIV rates among our people who inject drugs through evidence-based interventions such as methadone program, the needle and syringe exchange program. And for HIV positive people who use drugs, the combination of these interventions have been shown to improve uptake of HIV care. And there is an estimation of more than 100,000 people who get drugs in the country, but the Malaysian Ministry of Health estimated that only 38.9% of people who inject drugs ever tested for HIV, and among those knowing their status, only 34.6% of them are receiving far below the global targets. And as part of the Samara study funded by the RG grant, in which I serve as the principal investigator, I would like to draw your attention to sub-program 1, which looks at first a cross-sectional study using respondent-driven sampling, followed by a longitudinal interventional cohort. So in the second phase, our implementation strategy would be to have a community-based patient navigation model that would link people to treatment as needed. And we are optimizing the role of local community-based organizations to do this. And this work is being conducted by our PhD student, Jocelyn Pang, who is also one of the Miss Scholars trained in implementation science. So the implementation strategy that we are applying leverages on the roles of peers, the community health workers who, unlike professionals, share key personal characteristics, lived experience, circumstances with the targeted population, and a systematic process and a personalized approach, going through rapport building, goal setting, barrier identification, and asset mapping, action planning to address clients' needs and priorities. And the goal is to create an enabling environment so that more people are enrolled in evidence-based practices such as art, methadone, and Hep C treatment. And we completed the first phase of the study and found high proportions of people who inject drugs who have yet to start on this treatment aligned with national and global data, despite the urgent need to start them on treatment, and also despite the availability of no-cost ART in health clinics. And our community partner, whom we have been working closely with, Persatuan Insaf Murni Malaysia, is an NGO established in 2006, focuses on harm reduction programs based on the outreach model of care, including delivery of needle and syringe exchange program and referrals to methadone and also HIV care. And the idea of community engagement as the core value of Samara, in a way that we try as much as we can to adhere to the principles of community-based participatory research, is what I think makes this beautiful, makes this research beautiful, because we try to engage community members, community healthcare workers who are working on the ground, peer workers who are also part of the people who inject drugs community, going beyond engaging community as just study participants. So they have been instrumental in the process, the whole process of research, right from planning and design, implementation, engagement, and we hope to be able, we hope that we are able to engage them in research dissemination processes where they'll be involved in manuscript writing and talks with the community. So the specific aims of the study includes to understand the patient, provider, and governmental barriers and facilitators for using computer-based patient navigation to engage participants in HIV care, to develop a detailed plan to implement a strategy to facilitate the uptake, and to implement adaptive strategy with 150 people who inject drugs. And we want to be able to measure the number of people referred to care, to methadone, to ART, Hep C, and our study flow includes a qualitative component in our preparatory stage based on the APIS framework by conducting focus group discussions with different groups, the NGO administrative staff, their peers, the community health workers, and also clinic staff at the Panamaran Health Clinic in Klang. And as we implement the strategy, we would also do a bi-weekly and monthly updates with the NGO to see the progress of the implementation. Some photos from the Smara phase 1 study, which has been completed, and we are about to embark on our second phase. And I'm more than happy to talk about this research with anyone who would be interested in the study. And before I end, I'd like to share a bit about what my MISS journey had looked like. Before that, a quick introduction about the MISS program. So in collaboration with Yale University, was awarded with a 5-year Fogati grant. So the MISS program is the first HIV and implementation science training scheme in Malaysia that incorporates a human rights focus, running from 2020 to 2024, led by Professor Vic Altis from Yale and also Professor Adiba Kamruzaman from our faculty. So this program aims to institutionalize implementation science in Malaysia by training faculty members, and doctoral candidates will then train the next generation of researchers and implementers, which is exactly what I'm trying to do now as one of the many, many platforms. So all MISS scholars are expected to spend 2 terms during the training. The winter term, which we did virtually, was a series of lectures on frontiers in public health and the basis of implementation science. And during the spring term, we were all expected to spend time in Yale between January and May. And these are the courses that I thought have been really useful in shaping the way that I think about my implementation science research, particularly the community-based participatory research in public health, which has become my personal favorite. So before I end, I would like to take this opportunity to wish everyone Selamat Hari Merdeka. And my hope is that we can all come together as researchers to help our country move forward. And if we don't have enough time for Q&A, sorry for that, I'd be happy to communicate with you through emails. My WhatsApp number is up there, and I'm also on Twitter solely for academic and advocacy purposes. Thank you.
All right, thank you very much, Dr. Afiqah. I think it's very interesting to share your experience in implementation science and also the MISS project in Malaysia. So there's no question now, but let me start by asking you. So as a researcher in or Faculty of Medicine, how do I actually go into implementation science research? What is my avenue?
Sorry, Robert, can you rephrase the question?
As a researcher in University of Malaysia,
yeah,
or in Faculty of Medicine, what is my avenue to go into implementation research or implementation science research? How can I start?
It depends on, first, I think there are a few components in implementation science that you need to know. First, what is the evidence-based practice that you feel is lacking in terms of uptake in your own area of work? And second, to identify what would be the strategy that you want to apply in improving the uptake of this evidence-based practice. And third, you would need to identify what would be the methods or the theories or even the frameworks that you would like to apply in making sure that you are able to implement, not just to implement, but also to evaluate the implementation outcomes, whether or not the uptake of this strategy, the application of this strategy would improve the uptake of the evidence-based practice of your intended intervention. I think that's pretty much the first step to move forward.
It is good. Let us ask whether there's any question from the floor. You basically can put it through the Q&A. There's a Q&A button on your when you're logged in to this session. Most of the thing you talk about is basically we will just wait. If there's no question, I'll just continue. All right. So there's a question. All right. Also, from Yoon Kun Chan, academic institutions have often been described as ivory towers because they lack communication outwards of their research. How many implementation scientists do we have, and how can we actually focus on ensuring every research is aware that needs to know implementation science? This is from YK Chan.
Yeah.
Prof. YK Chan.
That's a really good question. I can't really answer how many implementation scientists do we have in Malaysia, but I'm guessing everyone, I mean, some of the researchers that we have in our faculty or even in other universities may actually be doing implementation science, but not realizing that what they're doing is implementation science. So what we hope to do is to establish a platform where we have all the resources for these researchers to pick in order for them to move forward with their research. And I think that's what we're trying to do with the MISS program. One is to do what we have just conducted in the past back in July is the MISS bootcamp workshop. So this is where researchers from not just the universities, but also people from the Ministry of Health come in to really look at the science of implementation research and to look at what are the tools available there so that when they do implementation research, it is being done in a systematic way.
Okay, so how do I actually get access to MISS?
The MISS program?
Yeah, basically, I'm a researcher I'm a researcher currently in UM and also outside maybe, but how do I get access to MISS? What is the venue for that?
So what MISS offers is also not just bootcamp that I just mentioned just now, but we also have, for instance, myself.
No, the question is how do I go and get access to MISS? Not what MISS offer.
We are establishing research workshops and also bootcamps, and these are being advertised as we go on, and these are the avenues that you can go to if you're interested in implementation science. And
where's the advertisement?
For now, we don't have yet in the planning, but we will update everyone in case everyone is interested. And you might also want to follow the SPM website and also the Twitter accounts. That's where we are going to highlight on the in case any workshops or conferences are happening, and these are the places that you can go to see to get more updates.
Very good. That's a good way to go forward. So there's another question, I think. All right. Is it really tough? Is it really a tough step to get your research to implementation? It is really a tough step. That's what she was making a comment. Okay, there's Prof. Tungku Sarah. All right. From finance to how best to carry it out. It's already difficult to carry out the initial research in an important matter. Very frustrating, where we often feel blind are leading the blind. Yeah, basically, I think it's. I mean, what is your thoughts on that? So are we basically just going round and round?
Yeah, I mean, I agree with that. It's a very tough step to get from research to implementation, which is why we're seeing the 17 years odyssey. You have the evidence, but to get that into practice, it would take 17 years. There's also issues on getting the project finance, which I think the reason why grants like the IRG is focusing more on the impacts of research, looking at how that can be impactful, not just to us within the healthcare settings, but the larger community itself. So I think that's one avenue to look at. And I think, sure, it's a complicated process, and I think the key word here is to engage with more people, engage with the stakeholders. And when we speak about stakeholders, it's not necessarily from people from the academic side, not just the management side, but also going down to the ground to talk to our implementers and also patients who are actually delivering, who are actually receiving the intervention.
Okay, last question. What's the difference between implementation science and participatory research?
So community participatory research is a component that we use in implementation science. It's one of the many skills and techniques and methods to make sure that the implementation science is moving forward, and that our implementation strategy is being evaluated in a way that we're engaging engaging our relevant stakeholders in the process.
All right, thank you very much. I think we come to the end of the session today, and I don't want to keep you all because you have a very busy day. And thank you very much. If you have any question, you can actually email Dr. Afiqah. She will be very, very, very interested to answer your question, and also to basically advertise our what we are doing in the Faculty of Medicine in University of Malaysia, basically together with Prof. Adiba, and also from the WHO. Sorry, from Ministry of Health, and also from the United Nations University on Global Health. Basically, we are starting up a implementation research project, and basically we are continuously doing the MISS program. So as mentioned by Dr. Afiqah, that if you want more information, you can go to our website or our Facebook page. So the website address is spm.um.edu.my, and the Facebook page is facebook.com/PH public PHGrads, so PHGRADS. Thank you very much, and have a nice day. And thank you for the people who behind breakfast at I think I have a good breakfast, and basically I can have a good day ahead of me. Thank you. Bye, everyone.